Ma'am, we are live now.
Bismillahirrahmanirrahim. I welcome you all to a webinar on fetal growth restriction. And I welcome to all the members, the president, and worthy members of Society of Obstetricians and Gynecologists. So as we see that this is a very important topic because fetal growth restriction is a major cause of perinatal morbidity and mortality. The large number of stillbirths that we see, they also get a contribution from fetal growth restriction. Things have not been very clear in this respect. We still find it at times very difficult to just define which of the babies are growth restricted, which are just small for the gestational age, and there remains a small area where it becomes very difficult to get even a definition of fetal growth restriction. And fetal growth within the uterus, it's not a very easy thing to look upon and to say what are the factors which contribute to the fetal growth. But some of the things are very clear that if the placental blood supply to the baby is diminished, then there will be a problem in the fetal growth. But having said that, it is not that simple. We must take into account the genetic makeup of the baby, then something which is coming up and is known as the epigenetics. We must know about that. And finally, we must know about the insulin growth factor, how it influences combining with the receptors to promote the fetal growth in utero. So with this preamble in mind, the diagnosis and the management of fetal growth remains difficult, and the diagnosis that it is a growth restricted baby, because we have to make the diagnosis in utero, it becomes very important for the obstetrician. So today's webinar is on this important topic. And now I would request Professor Razia Korejo, the President of SOGP, for her welcome address. Madam, please give your welcome address.
Rahim. They are all SOGP members, healthcare providers, all the panelists, speakers, moderators, Assalamu alaikum. On behalf of SOGP, it is a great pleasure for me to welcome you all today in this very important webinar, that is the IUGR and its management. As all of you know, that IUGR is associated with a high perinatal mortality and morbidity, but also there is an increased risk of morbidity in adult life. So initial evaluation of the patients who develop the IUGR is very important. It is very challenging for all the obstetricians to diagnose it early and its management and its properly deliver at appropriate time. The diagnosis is very important. It is usually based on the history, examination, and investigations. As part of the history, that is very important. We have to take the proper history to find out the possible maternal risk factors. In this way, you have to diagnose the risk factor, and then you can manage it properly. The role of the ultrasound is in diagnosis of IUGR is very important, because the ultrasound will tell us the exact date of the gestational age, to exclude congenital malformation of the fetus, and also the amount of the amniotic fluid. So the ultrasound is very important. The Doppler ultrasound is also very important, but it is usually not diagnosed, but it usually gives the strength of the IUGR. It will also very helpful in the management of the patient, because it will tell us the growth of the fetus, umbilical artery, diastolic potential flow in the umbilical artery, and the normality of the fetus. So today we have called very experts who will give the information about this, how to diagnose the IUGR, how to manage, and what is the role of the ultrasound. As all of you know, that today's the speakers are the Professor Shama Mariam. She is very well known in the fetal medicine, and Dr. Musarrat Hasan, who is the pioneer of the ultrasound. So they will tell you about how to diagnose the IUGR and the how it will manage it, what is the role of the ultrasound doctor in the management or in the diagnostic of the IUGR. So I am very thankful to the worthy speakers, Dr. Musarrat Hasan and Dr. Shama Munim, for giving their valuable time for today's webinar. And also I'm very thankful to moderator Professor Nudrat, Sohail, who has also given us time for this moderation of this webinar. And I am also thankful to the panelists who are the Dr. Naseem Saba and Dr. Mariam Zubair, and Professor Muhammad Tayyab. They are very academic person, and they are the panelists. They will tell you, they will conclude this session, and I hope after today's discussion, every one of our healthcare providers will get benefit from today's discussion, because this is very important topic. So I am thankful to all of them, speakers, moderators, panelists, for giving valuable, precious time to this webinar. At the end, I am also very helpful to the SAMI Pharmaceutical Company for supporting in organizing this type of the webinar. SAMI Pharmaceutical Company is I'm very thankful to them, because in this COVID-19 situation, they have supported us a lot. So I am thankful to them. I hope, inshallah, they will continue to. So in the other activities, they will also help us. Thank you so much.
Thank you very much, Professor Razia Korejo, for your very valuable comments and the welcome address. Now, for the first talk for today's webinar, I would request Professor Shama Munim, who's the chair of the Maternal-Fetal Medicine Subcommittee and also one of the member of the core group of SOGP. She is a very renowned professor when it comes to dealing with the babies in utero. She is one of the pioneers for fetal medicines in Pakistan. Madam, we welcome you to the webinar, and we are anxiously waiting for your talk. Over to you, Madam Shama.
Thank you very much, Professor Nudrat, for that elaborate introduction. Without any delay, I would like to share my slides and see. Have you got my slides? Can you all see my slides?
Yes, ma'am, it's visible.
Okay.
Visible.
So fetal growth restriction is a very important topic, and as you've already highlighted its importance, this is something which is very close to my heart, and it's a pleasure to be here. And first of all, I would like to thank the organizers for giving me this opportunity. Now, there has been a lot of clinical dilemmas that we face in everyday clinical practice because of fetal growth restriction and the gestational age at which we encounter such problems, and moreover, the outcomes we are worried about. And there has been a tremendous research that has gone in the last 2 decades, and I would try to give you a little bit of flavor. It's not, I won't be able to do justice to each and every sort of aspect of it. So in terms of definition, there are 2 definitions that we are working with. There is one which is called fetal growth restriction, where the fetus has failed to reach its own genetic growth potential. And another definition, which is used synonymously, is small for gestational age, which means that the fetal growth is below a predicted threshold for a gestational period, which is commonly taken as estimated fetal weight or abdominal circumference less than 10th centile. The importance is already known to us that the perinatal morbidity and mortality of fetal growth restriction is very high. It is almost 4 to 6 times higher compared to normal weight babies. And above all, as Professor Nudrat has highlighted, that there is a high risk of stillbirths. And if you look at this graph, you see a lot of stillbirths in growth restricted babies, and almost 40% of the growth restricted babies are not born alive. Now, the slide which is below is actually the classification of stillbirths. And years ago, when we used to use Wigglesworth classification, we had a huge chunk of stillbirths which were labeled as unexplained. From the time that we have started using centiles and we have put these babies into centiles, this is called recode, and you find that nearly 40% of them or 42% of them are growth restricted. And that is a cause of stillbirth. In terms of morbidity, there are both short and long-term morbidity associated to this condition, mainly because of premature delivery, respiratory distress syndrome, neonatal encephalopathy, and necrotizing enterocolitis. In terms of long-term sequelae and the cerebral palsy, developmental delay, and chronic lung disease and cardiovascular complications. We are all aware that this disease has a programming effect on the adult life also. Now, for years, we used to think that small for gestational age is the same as fetal growth restriction. And then many people said that SDA means constitutionally small, so it does not mean anything, and it probably has a good outcome. But there are several studies which have refuted this and has found a severe adverse effects both in the SGA babies in terms of perinatal outcome and neurological or neurodevelopmental delay. Now, more recently, the fetal growth restriction has been divided into 2 types based on the initial diagnosis made at the gestational age. Early fetal growth restriction is all those cases that are diagnosed below 32 weeks of gestation, and late being the ones that are diagnosed later on. And the late fetal growth restriction accounts for about 70 to 80% of these cases, whereas early growth restriction is only 5 to 10% of cases. Early growth restriction is more commonly diagnosed, and late is difficult to diagnose. The early growth and actually the reason why this division took place or this classification took place was primarily that people felt that there was clinical etiology underlying disease, and the phenotype were all different, and it seems as if they are 2 separate entities. The early growth restriction is associated with preeclampsia or placental pathology, where umbilical artery Dopplers, ductus venosus, and biophysical profile can be abnormal. And therefore, the management remains a problem because one has to weigh the risk of prematurity against the risk of potential stillbirth. Hence, the management is difficult. In contrast, the late preeclampsia is a weak association in late fetal growth restriction, and most of the time the umbilical artery Doppler will remain normal, and your monitoring would depend on middle cerebral artery Doppler and cerebroplacental ratio. However, that management is easier because you are more towards term. So I'll touch very briefly on screening options. We know that there are maternal risk factors, which can be maternal demographic factors like age and underweight, or there may be medical conditions like hypertension and diabetes. And these are the maternal risk factors that you can outline in your first antenatal visit and stratify your women into high risk and low risk based on that. We have the option of having ultrasound-based screening by uterine artery Doppler, and there are biochemical markers like PLGF and PAPE and others, but in the interest of time, I will not touch upon them. Now, briefly on the use of maternal characteristics, it has been found that if you use the maternal characteristics, it will only predict 37% of women who would subsequently have small for gestational age, and the false positive is about 10%. The other screening option that I think we all use is a symphysis of fundal height, and we do it on everyday basis and has found a sensitivity of around 85%. More recently, the researchers have shown that a single measurement, if you don't take the measurements every time, but you do one measurement snapshot between 32 to 34 weeks of gestation, it has a higher sensitivity of 85% with a specificity of 96%. Moving on to the uterine artery Doppler, which actually reflects the uteroplacental blood flow. It actually tells you about the trophoblastic invasion and the impedance in the spiral arteries. As you know that in the initial part, the trophoblastic invasion is not complete, and then as the pregnancy progresses, it becomes better and results in low resistance in the spiral arteries. The things that we use to measure are the uterine artery PI and see the notching that you can see. And on the lower side, we have the umbilical artery because that's the interface that we are talking about. Now, and as I said that the impedance is high in the first trimester, it gets better. Uterine artery is used both in the first and the second trimester for screening for fetal growth restriction. And we've already talked in the first trimester, uterine artery predicts about 60% of cases with a false positive of 10%. There is very little value to actually repeat once you find it abnormal. Now, the importance of uterine artery is that we have an intervention like aspirin present, and more recently in the meta-analysis, aspirin has seen to reduce the risk of fetal growth restriction in high-risk women by half, with a relative risk of 0.5, provided you start your aspirin before or at 16 weeks of gestation, and the recommended dose is between 100 to 150. It has been seen that the evening dose of aspirin is more effective than the morning dose. However, the recent SMFM and ACOG guidelines do not promote this or endorse this, and they say that the most of the studies on aspirin have been done on preeclampsia and are not done directly on the fetal growth restriction, and nor do they recommend the use of low dose molecular weight heparin in repeated fetal growth restriction. Moving on to our main topic, which is diagnosis of fetal growth restriction. We all are aware that the accurate dating of pregnancy by crown rump length in the first trimester and head circumference in the second trimester is important and vital, because otherwise you're going to overdiagnose fetal growth restriction. Then the correctness of the correct use of measurements like head circumference, abdominal circumference, femur length, and calculating the estimated fetal weight with effective formulas and more commonly Hadlock formulas is recommended. Once you find that the baby's measurements have been done, you plot them on the appropriate growth centile for biometry, and it has been recommended not to repeat biometry measurements less than 2 weeks of duration. Now, this is only to show you that how things have evolved, and there is more evidence to suggest that fetal growth charts, the use of fetal growth charts are important and vital. And I'm just going to spend a minute on our own study, which was a longitudinal study, because more commonly we've seen data from Pakistan on cross-sectional data, and we found this correlates very well with the diagnosis of fetal growth restriction. So basically, the body of evidence suggests the use of local or regional charts as they are more likely to identify fetuses below the 10th centile. And more recently, we have the intergrowth study, which was done on the premise that all babies are the same, and irrespective of their background, ethnicity, and others. And these charts are available on the internet, but it has been seen that these charts may actually overdiagnose small for gestational in low or middle income groups. Now that brings us to the second part of our talk, where we know that after we have highlighted and we have diagnosed fetal growth restriction, how do we differentiate between the two entities is by the use of Dopplers, which can be arterial or venous Dopplers. As I've already talked about the uterine artery, I'm just going to briefly reflect on this, that the Dopplers actually show the fetal adaptation to hypoxia and response to chronic malnutrition. And umbilical arterial Doppler and uterine artery are used to identify vascular bed resistance, while middle cerebral artery is used to identify the fetal adaptation by redistribution of blood to vital organs. And ductus venosus and umbilical vein, on the other hand, shows cardiac decompensation. So I think I'm going to spend a few minutes on umbilical artery Doppler. As it is the oldest that has been used, it is closely related to uteroplacental blood flow. It shows the first sign of hypoxia and compromise, quantitatively represented by raised umbilical artery PI and qualitatively by absent or reverse end-diastolic flow. Having said that, end-diastolic flow is often absent in the first trimester and improves with the advancing gestation. So we have the normal blood flow, which shows a chunky end-diastolic flow, and then we have an intermediate group of reverse end-diastolic flow or absent, and then we have reverse end-diastolic flow. The transition from reduced end-diastolic flow to absent or reverse end-diastolic flow may take days or weeks. So at the end, the absent or reverse end-diastolic flow is associated with increased perinatal morbidity and mortality and long-term neurological sequelae. Moving on to middle cerebral artery is used in conjunction with umbilical artery, and it is because it is easily reproducible and easily studied. It represents fetal adaptation to hypoxia, and the flow increases with the advancing gestation. So in the beginning, it's like without any end-diastolic flow, and it kind of mirror images the advancing gestation shows end-diastolic flow and looks like umbilical artery, but in the beginning, it's different. So the abnormal MCA fetuses not only have perinatal outcome effect, but 6 times more likely to be delivered by cesarean section, and hence the importance of MCA is in monitoring of late onset fetal growth restriction. More recently, we have been using the ratio of umbilical artery to middle cerebral artery, and it is called cerebroplacental ratio. And it is mainly diagnostic, and you can plot them, and you find that generally median is around 1.5. So it is shown to be having a best accuracy for perinatal death, and hence should be incorporated in routine practice. And if you find low PI or cerebral placental ratio in the absence of normal, in the presence of normal umbilical artery, it is associated with poor outcome. And then we move on to the venous Doppler. The ductus venosus is the one which actually shows the cardiac decompensation, and the alteration in the waveform is due to progressive dilatation of the ductus to improve the blood flow to the heart. So absent or reverse flow in the ductus can predict fetal acidemia, and if this is the case, the odds ratio of stillbirth is around 11 times more. And it is most often sort of recommended to use this with the computerized CTG, which we don't have, to improve the neurocognitive outcome. Now, this is just to show you that the first change that can occur most commonly is in the umbilical artery, and then over a period of time, things deteriorate, and CTG is the last one to go abnormal. And these are the phenotypes that we've already talked about. Moving on to the surveillance and delivery, it is important because I've already explained that the prematurity has to be weighed against the risk of stillbirth. Now, I've tried to make it a little flow chart to see how we actually going to work on this if we encounter somebody with abdominal circumference or estimated fetal weight below the 10th centile. So the first and foremost thing one has to do is to classify it into early or late, depending on the initial diagnosis. Once you having diagnosed, one has to look at the detailed anatomical survey, because often the early onset fetal growth restriction can be associated with chromosomal abnormalities, structural abnormalities, and therefore in many of the early onset fetal growth restriction, one advises invasive testing. And by invasive testing, I'm categorically saying is that you don't do a karyotype because you may not find anything wrong. And the gold standard is chromosomal microarray. And chromosomal microarray is also done in cases where you find early onset IUGR with polyhydramnios. Also, more importantly, there is recommendation to do CMV in the most of the US guidelines. However, there is practical implication. In terms of surveillance of fetal growth restriction, you do Dopplers and CTG. And if there are CTG abnormalities, you would not prolong the pregnancy, or maybe if it's early pregnancy, very, very early, you may discuss with the parents whether they want to forego the pregnancy or they want you to go the whole extent of doing the monitoring. Moving on to the Doppler, and I've tried to divide them into, if you do a Doppler surveillance, the first Doppler you do is umbilical artery. What if you have a fetal growth restricted baby with a normal umbilical artery? How often do you do your biometry? As I've already said, you do your biometry every 2 weeks. But if the centile is between 3rd and 9th, or almost 9.9, you do your Dopplers once or twice weekly, and you would do actually a CTG once weekly. If you have a severely growth restricted fetus, then you would definitely do Dopplers every week, and you plan to deliver this patient by 37 weeks of gestation. If there is around 9.9 or 10, maybe you can delay delivery till 38 or 39, provided you are still monitoring the patient. In terms of reduced end-diastolic flow, this is the group that we always encounter, that you get a report and you say mildly reduced or moderately reduced end-diastolic flow. What do you do then? How often would you repeat the Dopplers? This is the case where you would repeat the Doppler once or twice and do a maybe twice weekly CTG. And again, the biometry, there is no role of doing biometry less than 2 weeks, but plan to deliver at 37 weeks. Moving on to the group with severe findings like absent or reverse end-diastolic flow. As I've already said, if there is a very, very small fetus with a very early pregnancy, you would have to discuss with the patient about the future wishes and other things. Otherwise, whenever you diagnose, you consider them inpatient admission. If they are willing, and give corticosteroids, do 2 to 3 times a week umbilical artery and other parameters like ductors, and do a CTG bi-weekly. And if it is an outpatient and you plan to deliver your patient by 33 or 34 weeks of gestation. And moving on to the ones with reverse end-diastolic flow, in addition to the same that you would do for the absent end-diastolic flow, you would plan to deliver them by 30 to 32 weeks of gestation, and you would give them magnesium sulfate if there's less than 32 weeks of gestation, because there is. Now, this is just to compare how things vary between the American or the European side. Most of the European studies or the latest ISWOG guidelines shows that if you have a late onset fetal growth restriction, you would do twice weekly umbilical artery and MCA and cerebral placental ratio, and you would do weekly in the early onset fetal growth restriction. In terms of how do you deliver them, by far most of the severe forms of fetal growth restriction, those with absent ductus venosus flow, absent or reverse end-diastolic flow, would be delivered by cesarean section. Having said that, the vaginal delivery by induction can be contemplated in those with normal Dopplers and fetal growth restriction, or fetal growth restriction with normal AFI or oligohydramnios, irrespective. Now, again, what does the ISWOG guideline says is that you would reserve your cesarean section for those with abnormal CTG, ductus venosus, and alteration in the biophysical profile or maternal conditions. And in the absence of that, there is no contraindication. You can do induction of labor in a well-equipped unit. So the take-home message from me today is that fetal growth alone, size alone, is not sufficient to diagnose fetal growth restriction unless the abdominal circumference or estimated fetal weight is below the 3rd centile, which means that on the basis of biometry, unless it's severe fetal growth restriction, you cannot say that. You would need the use of Dopplers, because that would distinguish between the fetal growth restriction and small for gestational age. It is important to know the early or late fetal growth restriction, as they are different entities. Umbilical artery Doppler and ductus venosus are mainly used for early onset fetal growth restriction monitoring, while MCA and cerebral placental ratio is used for the late fetal growth restriction. Thank you very much for your attention.
Okay, thank you very much, madam. It was a very informative talk. We really enjoyed it, and we are now much more wiser than we were before. And you have highlighted very important points in SGA versus IUGR, the diagnosis, and the latest development in measuring the ductus venosus flow, as well as commenting on very important things. So thank you very much, madam. And now, after thanking Professor Shama Munim for her very informative talk, I would now request Dr. Musarrat Hasan for his talk. He is currently the chair of Ultrasound Subcommittee of SOGP, and he has been the president of Society of Ultrasound of Pakistan. Sir, we are waiting for your talk, please.
All right. Bismillahirrahmanirrahim. In the name of Allah, the Gracious, the Most Merciful. I would first like to thank Professor Haleema Yasmin of SOGP for inviting me to this forum. And I hope you enjoy my talk on role of ultrasound and Doppler in IUGR. So let me now share the screen and okay, so this presentation comes to you from our Institute of Ultrasound Imaging, the Learning Center, which is affiliated with Thomas Jefferson University Hospital, Philadelphia, United States of America. So we are going to talk about intrauterine growth restricted fetus. The definition would be most appropriate or clinically applicable is estimated fetal weight below 50th percentile. And AC is the most sensitive indicator for making such a diagnosis. This is the ultrasound image of twin pregnancy, where you can see the circumference of the one fetus, body of the first fetus, and the circumference of the body of the other fetus. This one is smaller and this is slightly bigger, telling us that this is lacking behind, or there is growth restriction when we compare the two. Why we are interested in doing this study is to determine whether the fetus is growing all right or is lacking behind from the normal growth. The most important parameter which we are going to deal with is the abdominal circumference, which calculates the weight of the baby. And if the weight of the baby is below the percentile, we start to suspect that there is growth restriction. The fetus is looking at the calendar that when you are going to take me out. So what we are basically determining is that whether the fetus is comfortable inside with all the amniotic fluid and placenta and the movement, or the situation is too bad inside so that we need to take it out. So that's why weight, the thriving of the fetus, amniotic fluid, the surrounding, all have to be taken into consideration. Etiology, of course, maternal factors, fetal factors, uteroplacental factors. Maternal factors, you already know: maternal height, weight, ethnic groups, socioeconomic groups, and nutritional support. Hypertensive, preeclampsia, renal disease, long-standing diabetes. Fetal factors would include chromosomal disorders, which is basically diagnosed by the 2D ultrasound, which we do it vigorously. Infections, multiple pregnancy, and sex-linked diseases like Turner syndrome. When it comes to uteroplacental factor, which is going to be our topic today, we have to see the reduced functional area, whether the placenta is thin, small, reduced uteroplacental blood flow, which is determined by color Doppler, whether the adequate amount of blood flow is being provided to the fetus. And of course, maternal hypertensive diseases in the pregnancy, which means less blood is coming to the uterus. Etiology of IUGR remains idiopathic in approximately 35% of the cases, so we might not be able to know the exact clue. When it comes to perinatal mortality, newborn weighing 1.5 to 2.5 kg is 5 to 30 times greater risk, whereas newborn less than 1.5 kg is 70 to 100% times greater risk. And that's why we say more severe the IUGR, higher the perinatal mortality. As far as perinatal morbidity is concerned, 10 to 30% are associated with minor or major congenital abnormalities, 30 to 50% of intrapartum fetal asphyxia, and we have noticed learning disabilities in 1/3 of patients. We can have two types. One is symmetrical IUGR or asymmetrical. We are lucky that the number of asymmetrical is higher. It's easy to diagnose and very difficult to diagnose symmetrical IUGR unless we start suspecting it in the first trimester. Nutritional support defines those two entities. poor nutrition early in pregnancy, which will result in decreased cell number, and poor nutrition late in pregnancy, which restricts the cell size. And that leads to, of course, the symmetrical or asymmetrical. When it comes to asymmetrical growth restriction, its head to body ratio is abnormal. And that's why it's easy to diagnose with the parameters which we have. If the circumference is less than this circumference of the head, we start to suspect something is going wrong, and it starts late in pregnancy. Abdominal circumference less than normal is what we try to pinpoint. As far as the LMP is concerned, most of the patients might not remember. One could be lactational amenorrhea. The patient may be coming from a rural area where she doesn't remember, and she might say that I had the Eid was there, or when Eid was there, and you keep on calculating, so you don't get the exact figure that when the LMP was. If we know first day of the last menstrual period that the LMP is this, it's very easy to calculate the growth parameters. But if that entity is not known to us, we move on to ultrasound. We look for any previous ultrasound done, which will be the important landmark. The reason being that if ultrasound is done in the first trimester at CRL level, which according to WHO says that it is the most accurate time to date the pregnancy, if that ultrasound was done, then it's easy to calculate the growth at a later stage, that it is not corresponding or it is corresponding. But if this is also not available, which is done by biometry, BPD, femur length, AC, HC, and HC-AC ratio, then we move on to the third parameter, which is called the growth percentile for diagnosing IUGR. This is the most very sensitive indicator for growth scan. But the problem with that is that you need to have at least 4 weeks to 6 weeks gap in between the two scans. And if you are scanning at 34 weeks, then it is quite possible that you might not get the chance of giving the patient more time for the next scan. So if it is done in the second trimester and then you have done another scan in the third trimester with an interval of 6 weeks, then this can be calculated with greater accuracy and is very, very important. Why we are interested? Because we wanted to know whether it is a small for gestational age baby or it is deviating from -2 standard deviation, which results into IUGR. So these dotted lines, when you plot first scan, second scan, or third scan, and it deviates way beyond, that means it's leading to IUGR. Suppose we don't know LMP, suppose there is no previous ultrasound done, we don't have enough time to do the percentile, then we go to the next stage, and that is look at the status of the amniotic fluid and placental gradient. If the placenta, as you can see in this one, has cotyledons formation, infarction, and calcification, which means there are 3 things altogether in this placenta, which means it's grade 3 placenta. That is pointing to the maturity of the placenta. And if you look at the fluid, which is hardly any fluid, because this is all umbilical cord, so there's no amniotic fluid. These are the 2 parameters, along with all the biometry, triggers our mind that there's something wrong going on, and what would be the next. And the next is do the color Doppler ultrasound to evaluate the blood flow from the mother to the uterus, to the placenta, and from the placenta to the umbilical cord, and umbilical cord to the fetus. So we are determining at different stages. This is a picture which I took in FIGO conference in Rio de Janeiro, and I visited this bird park. And when I saw this parrot, I said, oh, wonderful picture to say that when we talk of color Doppler, all the colors which you see in this parrot, lighter shades, darker shades of blue, red, yellow, white, black. They are all the components of color Doppler. So here we can see the B mode, and we can see the ROI, which is region of interest for Doppler, and we can pick up the colors from the umbilical cord, and wherever there are light colors, that's where we put the sample gate. And once we put the sample gate, we obtain the spectrum on the left-hand side. So this is also called as triplex mode. If you see Doppler spectrum, if you see B mode, and you see color, that's triplex mode. The other entity is called Doppler duplex. That means if you can see only spectrum or B mode and you don't have the color. How Doppler is presented, of course, spectrum is the backbone of every image. We can also determine by audible sound in some cases that something is going wrong terribly. And those who are experts can see only colors and make the diagnosis. But for general purpose, I think a spectrum, because you can calculate, you can present, you can document, you can reproduce. So spectrum is the integral part of the document. Just to give you an idea that we see the red color and blue color, let me tell you that red always does not mean artery and blue always does not mean vein. It's towards the probe and away from the probe, which makes it red and blue. So it is important that what is towards the probe is red and what is away from the probe is blue, and it could be vice versa. We can obtain the sample gate from the vessel and obtain the sound. And not only that, we can also get the spectrum side by side. This is what we call it as a duplex scan, because it does not show color and it takes two things together. One is the spectrum, other one is the B mode. So as I said that the spectrum analysis is the most crucial part in the color Doppler, so we must know more about it. Doppler hypothesis is determining abnormal blood flow in the placenta, elevated vascular resistance, which results in insufficiency, and I put it in IUGR in bracket, because Doppler diagnosed insufficiency, not IUGR, but insufficiency leads to IUGR. That's why we interchangeably use it. Doppler showed IUGR or Doppler showed insufficiency. And we can have the indices accurately measured as far as the resistance is concerned. Now, the other hypothesis is whenever there will be resistance in the blood vessel, there will be a drop in the diastolic flow, or we call it decreasing diastolic flow. And that would always increase the pulsatility index or indices, which means the number will increase. So when the number is high, means that there is less of diastolic and increased resistance. And when it's the other way around, the diastolic is more, that means the pulsatility index numbers will be lower. When we do Doppler of CDU and spectral. Why we do color Doppler? Because when I learned Doppler way back in 1982 at Jefferson, and then I had my first duplex Doppler at my clinic in Karachi in 1986, and it used to take me 45 minutes to do the scan. But today, with the help of the color Doppler, it takes me 5 minutes. Why? Because I put the ROI, the region of interest, I spot the colors in the vessel, and I put my sample gate right away and obtain the spectrum right away. So it shortens the examination time as far as the color is concerned. So we go in sequence. When it's an early scan, which is up to 26 weeks, symmetrical IUGR, do Doppler of the uterine artery vigorously, uteroplacental flow, and umbilical cord. This is $1 million slide. which is pointing out to a small fetus, and various spectrums are obtained. But the key factor is that, which I want to emphasize, when the size of the fetus is smaller, the spectrum is different. And when the fetus goes bigger, it needs more blood, the spectrum changes. So what is spectrum are seen in the first trimester may not be seen in the second trimester or third trimester. The key factor is that as the blood goes more to the fetus, the diastolic component increases. So what is what at what time, we must know that. And that's a very important slide. Just trying to tell you that there is a uterine artery which will always have a sharp notch. The middle cerebral artery will not have diastolic flow at all because it's very early pregnancy. This is not the factor. This is not the situation when it is in second trimester or third trimester. So we must know, and there is a pulsatile flow in the vein, and there's absent diastolic flow. This is normal for this gestational age. This is a patient who is pregnant, and when we see early pregnancy, less than 12 weeks, we always do the uterine artery and look for the notch. Sharper the notch, the V, sharper the notch means more resistance. I don't have to do any measurement at this time. The sharper the notch means, now what is important? This notch, as the pregnancy grows, will convert into a hump, which means that the high resistance is converting into low resistance flow between the gestational age of 14 to 16 weeks. So before 14 weeks, if you see notch, it's all right. If you see notch after 16 weeks, you get to worry about. Let me show you the next picture. Now, this is not sharp. There is a hump. This is the hump, which means that the diastolic component has flattened out, and that means the resistance is changing to low resistance. That means more blood is going, which is normal. And when the pregnancy advances, we see the diastolic, start of the diastolic, end of the diastolic, and we don't see the notch. This is normal when you go into second trimester or third trimester. And when we go into the third trimester, the same pattern, systole, and now we don't even see the start of the diastole, we only see end diastole. And we always measure from baseline to the end diastole to determine the values. We call SD ratio, or we call RI, or we call PI. We'll talk about that a little later. So once we have come to low resistance flow, we are not worried. Remember, if you're doing an early pregnancy, around 10 weeks, there will be no diastolic, absolutely normal. And there will be a pulsatile flow in the vein. There will be the dipping in right here, which is normal for that gestational. It's not normal for second and third trimester. Now, if there is too much of twisting of the umbilical cord, which is going to cause resistance in the blood flow, it is seen as a beaded appearance. You see color, you see gap, you see color, you see gap, you see color, and you see gap. This is because of the excessive twisting of the cord. And when you do the Doppler of that, it results into absent diastolic. This is systole, and there's no diastole. And this is the venous at the back. So this means it's causing resistance in the fetus. And that's not good for the fetus. Just to give you a comparison, this is the ROI, region of interest, not RENA ROI of India. Here is the umbilical cord. And wherever you see lighter shades of gray, that's the point where you put the sample cake, because you get the best spectrum. Don't take the flow from the darker shades of red or blue or yellow. So here we can see, now we can see this is the baseline, and that's the diastolic flow. So it has to correlate with the gestational age. Now, what causes resistance? We are already aware of that the uterine arteries, segmental branches, and it results into the spiral arteries, which are coiled. And when the pregnancy increases, this coiling is uncoiled. It becomes a straight line. At this time, there is resistance because it's coiled. But when it is straight line, then it is going to go faster. More blood is going. And there will be another term used, which I'm going to talk later, a little later in the next slide. So when we talk about asymmetrical IUGR, which is after 28 weeks of pregnancy, we do the Doppler of the umbilical cord artery, umbilical cord vein, renal perfusion, ductus venosus, and middle cerebral artery. These are the 5 places where we do the Doppler. Now, when we do Doppler, we are concerned with maternal Doppler, umbilical cord Doppler, and fetal Doppler. So let's see what we have in maternal Doppler. What includes maternal Doppler? We do the uterine artery Doppler, which is a part of the maternal, and we take the uteroplacental because it's a part of the uterine and placenta, so we take uteroplacental flow as a part of the maternal Doppler. So what do? We do the uterine artery, and we see this spectrum. We are very comfortable with this situation. And when it comes to placenta, asemiotic fluid placenta, this is the uteroplacental. Now, uteroplacental flow has got systole and diastole. Now, if the measurements of RI comes less than 0.50, means adequate blood supply is going to the placenta. And if the normal perfusion in the organs otherwise is 0.50 to 7.70, anything less than 0.50 means more perfusion. And anything more than the more perfusion means adequate blood supply to the placenta. That's what we are looking. When it comes to elevated uteroplacental ratio, elevated resistance probably at the spiral artery level because of that coiling, infection. And this is what I was talking about, trophoblastic invasion. So this sheds the inner wall to make the diameter of the spiral artery and the segmental branch bigger. More blood passes through because the fetus is bigger, it needs more blood. Muscular hyperplasia and placental thrombosis or tumors are other parameters to look. And you're aware of this slide, everybody has seen it. This is the umbilical cord, the chorionic plate, the exchange of blood, and the uterine wall. So this is what we are talking about. Doppler of the umbilical cord includes artery and vein. Artery, of course, we have already told you that we take the sample gate from the artery and we look for peak systolic, how fast it is moving, and the diastolic, how much is moving in that vessel. And we calculate the ratios for that and see whether it corresponds, that ratio corresponds with the gestational age or not. So what are the measurements? We have PI, RI ratios, SV, peak systolic velocity, and diastolic. Now, some people take PI all the time. I have categorized where to do SD ratio, where to do RI, where to do PI, and where to do PSV. And that's very significant. We'll talk about that later. This is just a formula for those of you who would like to note down that what is PI formula, what is RI formula. The problem is the more complicated the formula, the more error happens. So PI may have the error of plus minus 20, whereas SD ratio may have the error of plus minus 5. That's why in umbilical cord, we always take SD ratio, and I can debate on that if you have question answers at the end. So here we have the peak systolic, we have the end diastolic, and this is the mean. So we divide S divided by D, mean systole divided by diastolic, that gives you SD ratio, and so on and so forth. Very easy to remember what are the normal ratios in SD ratios. So it all depends on the gestational age, 20 weeks, 30 weeks, 40 weeks. So you crisscross At 20 weeks, it should be 4.0, 30 weeks, it should be 3.0, and 40 weeks. Very ready reference formula, and you can make up your mind, everything is fine. More than 28 weeks gestational age, SD ratio to be always correlated with the weight, which is calculated by, of course, AC, abdominal circumference. So more than 3, less than 5, we reported placental insufficiency. We don't write IUGR. Why? Because if the cord is around the neck, it will cause resistance. So I might write IUGR. Next day, I did the ultrasound, the cord came out, and there was no IUGR. So this doesn't happen. That's why you control yourself by writing placental insufficiency. Now we move on. More than 5, 7, less than 7, we use the word question mark insufficiency, question mark IUGR. 7 to 12, mild IUGR, and when there's no diastolic flow, and we'll explain these two entities a little later, moderate insufficiency, moderate IUGR, reversal of flow, severe insufficiency, severe IUGR. Now we have the spectrum, systole divided by diastole. We can get this ratio. If it is 18 weeks, it's fine. 16 weeks, 17 weeks, it's fine. But if it is 30 weeks, this is abnormal. So we have to make that point. You can do other readings as well, RI, SD ratios together, but stick to one as we have already said. Now, when we come to 36 weeks of pregnancy, we do the umbilical cord Doppler, and the ratio is 2.57. So we systole divided by diastole, because the diastole is increasing from the baseline. That means diastole is more. That means the amount of blood flow is going more, and that will reduce the number, which is normal. When it comes to absent diastolic flow, it is understood that it is moderate placental insufficiency, moderate IUGR. And we'll talk about that, why it happens. So here is this systole, and there's no diastolic component right here, absent diastolic. Now this means there is a reduction in the blood supply to the fetus, which can happen at any place. So when the amount of blood is reduced, let's say there is a retroplacental clot, more than half of the placenta is elevated. That means less blood will be going to the placenta, and we may see absent diastolic. That may lead to IUGR. This is a clinical emergency which one has to understand. And when it comes to reversal of diastolic flow, severe insufficiency, severe IUGR, and the images here, which I have defined, in fact, when the diastolic component is on the opposite side of the systole between the two systoles. That's a correct definition. Most of the books may not write this. So I don't, I've been doing Doppler since 1982, and I know what we are talking about. So this is what we call it, the reversal of flow. Now, in order to understand, there can be a polarity change in the image. So this systole may be down and diastole may be up, depending on when the cord is around the neck and you are going in this direction towards the probe and in this direction away from the probe, then this thing can happen. And I've reversed this for convenience, that the systole is on the top, the same image, diastole is below, but the definition remains the same, that the diastole is on the opposite side of the systole between the two systoles. If this diastole is right behind the systole, that's mirror artery. That's not reversible. People make that mistake very frequently. Why does that happen? It's a very interesting phenomenon. This is the placenta, that's the vein which is going towards the fetus. This is the umbilicus, and that's the artery coming from the fetus, deoxygenated blood coming towards. When the deoxygenated blood comes through those two arteries, which we are actually evaluating on Doppler, when it strikes the placenta, if the placenta is non-compliance, is hard because of calcification, because of cotyledons and infarction, the blood bounces back. And that bounces back is what we call it as a reversal of. Now we move on to the fetal Doppler, MCA, aorta, renal arteries, and ductus venosus. All are important, but MCA and ductus venosus are very important. These other two, the aorta and renal, triggers your mind that you have to do MCA, and ductus venosus. Why we do this? Remember, there is a redistribution of flow in the IUGR. So whenever we are doing the MCA, we are looking for the brain sparing phenomena, which may result into IUGR. That's why we do the middle cerebral artery in every patient if the patient has been referred for Doppler of the obstetrics. Now, at 30 weeks, 35 weeks, 40 weeks, this is the range, 0.80 to 0.98. And you don't have to remember this white figure, but you have to remember this orange one. This is 80, minus 5, 75, minus 5, 70. So 80, 75, 70. 30, you add 5, 35, you add 5, 40. Very easy to remember. Now we go to the next slide. I've added the green color. If at 30 weeks, the MCA is below 0.70, I should have added 0, but I did have a space. So 0.70, that means it's brain sparing phenomenon. That means at the cost of the body, more blood is going to the brain. That's what we call it as a brain sparing phenomenon. And that's what is very sensitive. We have seen that the umbilical cord Doppler was normal, but the MCA was abnormal. That was IUGR. And that needs immediate attention. So this is very sensitive, everybody should do that. On the contrary, why did I say peak systolic velocity? Because when we do the MCA, if the obstetrician or gynecologist asks me that, does this have anemia, that we have to move on to another reading, and that is peak systolic velocity. We don't do SD or PI or RIE. And when the hemoglobin is less, the viscosity of the blood is reduced. Means it is more fluid-like, means more faster movement. And faster movement means if it crosses more than 65 cm per second, you are dealing with anemia. Some people take it 70 cm. It's up to you, whichever chart you're following. I take it more than 65 cm per second as abnormal. Now here is the head where you can see the MCA. There are technical issues like what is the angle and how to obtain the images. I'm not going to go into the details. But when we obtain, look at the peak systolic, look at the end diastolic. The end diastolic is very less, which means it will go 0.80, which is absolutely normal. Now, when we come to the other one, the same the MCA we are evaluating, the diastolic has increased. This is what we call it as brain sparing phenomenon. So if the RI is less than 0.70, they're less than 0.65 or less than 0.60 at 30, 35, 40 weeks, we are dealing with IUGR. That's a very sensitive way to deal with this situation. Now, what triggers your mind is the aorta, fetal aorta. So if I don't see diastolic component, I do see in this one. But if there's no diastolic component, then I get to worry and I do MCA. So it's easy to obtain aorta. That's why you always do aorta. And that triggers your mind to do MCA and everything. You could also do cerebroplacental ratio, but remember one, that the values should be same. You cannot divide apples with oranges. You have to take either RI in both, or you have to take SG ratio in both, and then feed it into the chart and you'll get this. And that will be very sensitive to make the diagnosis. Coming to the vein, umbilical cord vein has phasic variation. If you look at the sound of the artery, it is like sh, 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 sh. But as far as the vein is concerned, the sound is something like sh. That is the vein sound. Now, when it becomes pulsatile, we may be dealing with either tricuspid regurgitation, fetal distress, check for an ovale, check ductus venosus when that happens. Why it is pulsatile. Now, this is the normal phasic variation in the vein. And now in this one, it's a straight line. There's no phasic variation. That's the start of the problem. It's not yet the problem, but that's the start of the problem. And once the umbilical vein has discontinuity, that means there is a dip in the vein, that means it is pulsatile. So pulsatile can be represented like this and can also represent like this. It looks like systole and diastole, but I'm writing venous. That means the vein is behaving like an artery, like pulsatile. We can argue on this patient for a long time, but this is definitely, I'm writing it. So that's why it is a vein. So this is pulsatile. Now, that's why when the umbilical cord vein is pulsatile, we move immediately to the ductus venosus. Ductus venosus is a short segment, which is a narrowing from the umbilical vein, which enters into the right atrium and hits the foramen vein. If there is a problem in that region, it's going to bounce back. And once it bounces back, it causes reversal of the atrial wave. And that's what is sensitive to make the diagnosis. So here we can see the right atrium, that's the ductus venosus. There's a sudden narrowing, which is normal. And once there is a foramen vein problem, or the tricuspid or the right atrium is larger, we get to worry about it, and we do the ductus venosus. Those of you who have done cardiology, they might have come across a machine type of murmur, and it sounds something like shh. If that happens, this is what the typical sound of the ductus venosus. That's normal. And we have got S and ES and D and A atrial contraction. We are concerned with the atrial contraction if there's any reversal of flow in that or not. So here is the systole, extrasystole notch, diastole, and atrial. And if that atrial is absent or is causing reversal, this is all artifact because of the vibrations. But if there is a reversal, and I'm going to show you one case, that is something to worry about. So here it is. This is systole, extrasystole notch, diastole, and the atrial contraction, there's a reversal. That's bad. If your setting of the machine is on the fetal cardiac, you'll always get the wrong reading in the ductus venosus. So look at the absence of the atrial wave right. The same patient, same time, this is a fetal heart setting, and I move on to obstetrical setting, it becomes normal. So there is a very good atrial, and this is all thumping of the vessel wall. So this is all artifact. We have to understand what is artifact and what is real. This is very important. Otherwise, every patient would be labeled abnormal. So here is a picture of normal, and here is a picture where is reversal, and that's reversal is bad. So we will see in the end what we can do about it. Now, how to use this spectrum in a clinical setup? When you see ratios, when you see absent flow, when you see reversal pulsatile flow, and flow in the vein, reversal in the ductus venosus, what does it mean to the clinician? What do we do after that? So let's go one by one. When there is decreased amniotic fluid, mature placenta, grade 3, normal Doppler in the umbilical cord to the middle cerebral artery and fetal artery becomes mandated. When there is absent diastolic flow, look for retroplacental bleed or clot. Repeat Doppler every 4 to 6 days and look for the umbilical vein pattern. This is very important because sometimes when the placenta is at the back of the fetus, we might not see the complete view of the placenta. And if there is a retroplacental clot, we may easily miss it. But Doppler can pick up absent diastolic flow, and that is something very significant. When the ratio is disturbed, what do we do? Repeat Doppler every week, check for cord around the neck, and fetal heart rate is the most important thing. Because if the heart rate is slow and you have done the Caesar, you might lose the baby anyway. So make sure that the heart rate is adequate. Reversal or reverse diastolic velocity or reversal of diastolic flow, whatever you like to call it, same thing. Repeat Doppler every alternate day. Look for umbilical vein hostility. See ductus venosus for reversal and monitor the MCA formations. This is something which you have to monitor. When there is reverse end-diastolic velocity seen with reversal of flow in the ductus venosus, now it's a combination of two. Decide the outcome within 6 hours, check the heart rate first. This is very important. And you have to take immediate decision what to do to save the baby. Now, some of the facts which you must always know, which very few people know. Umbilical cord artery, there's no diastolic flow before 14 weeks. That's absolutely normal. It is pulsatile flow before 14 weeks, umbilical cord vein, absolutely normal. Renal artery flow is always seen after 22 weeks, not before that. Before that, what is the criteria? You look at the urinary bladder. If the urinary bladder is there, that means the kidneys are functioning all right. But if it's after 22 weeks and the question is redistribution, then you do the renal artery Doppler. And same is true for the fetal aorta after 22 weeks of pregnancy. MCA diastolic flow after 22 weeks. Don't ask me at 16 weeks, what about the MCA? Because you will definitely see absent diastolic flow, that means reduced blood supply to MCA. And ductus venosus reversal is also before 22 weeks, so be careful. When to use Doppler? When you suspect IUGR, history or presence of hypertension, previous stillbirth, anomalous baby item, oligo, reduced fetal movement, premature labor, abruptio placentae, placenta previa or accreta, diabetes mellitus, multiple pregnancy, and chorioangiomas like tumors. Doppler should not be independently done without the B-mode findings. Must be used in conjunction with other information like fetal measurements, the growth, amniotic fluid, maternal history, risk factor, and ST results. So in the end, I would say give to the world the best you have and the best will come back to you. Thank you very much. If you have any questions, I've been in London at that time. So we will work out what will be the timing over there, because I'm flying on 15th, so 16th is your lecture. So we'll communicate with each other on Zoom. I hope you give me the password and other all the information, and hope you enjoyed the topic on IUGR. Wish you all the best and good luck, and thank you very much for having the patient hearing and enjoying the lecture. Thank you very much. Thank you. Thank you very much.
Thank you very much, Dr. Musarrat Hasan, for a very valuable talk. And as we had read that ultrasound has become the eyes, the hands, and the ears of the obstetrician, you have truly fulfilled that comment about ultrasound and the relationship which the obstetrician and the dependency which obstetrician has with the clinic ultrasonologist. So thank you very much for sharing with us all those beautiful colored Doppler photographs. Thank you very much, sir. And now we move on, and we move on for our panel discussion. For that, we have with us Professor Naseem Saba Mehsud. She's the chairperson of the Dera Ismail Khan chapter of SOGP. And with her is Dr. Mariam Zubair, who is the General Secretary of Muzaffarabad Azad Jammu and Kashmir chapter SOGP. So over to you. If we have any questions, we can just get them on the board. You can write them and we can share them on the screen.
It was a very nice and very elaborate presentation by two presenters. And I think that none of any corner which is left for discussion, because every aspect of etiology and then types of IUGR, they were presented in a very understandable way. The way how we can go for it, and for diagnosis, clinical, then in through ultrasonography, and then how we have to move forward for the management of that as well. So I think there is nothing left to add up to this presentation. These were extremely informative, even right for us. Thank you very much, Professor Shama, Munim, and Professor Musarrat. Thank you.
Assalamu alaikum.
So,
I second Madam Naseem Saba. Thank you very much, Professor Shama and Professor Musarrat, for enlightening us with such knowledge and very informative presentations. And we really enjoyed your talk. And practically, we as obstetricians, we encounter IUGR or fetal growth restriction very commonly in our daily practice. And one thing I just wanted to add for the information and interest of young obstetricians who have been listening us throughout this session, that during the assessment of patients, especially when the patients are coming to us at booking visits, we must rule out the risk factors of fetal growth restriction, and we should keep in mind that for one major risk factor of fetal growth restriction, or if somebody is presenting with 3 minor risk factors of fetal growth restriction, we have to offer patients uterine artery Doppler or umbilical artery Doppler and serial growth scans, depending upon the criteria of risk factors, whether they are major risk factors. If they are major risk factors, we have to offer them serial growth scans and umbilical artery Doppler at 26 to 28 weeks. And for 3 or more minor risk factors, we have to offer uterine artery Doppler at 20 to 24 weeks. So thank you very much, Professor Haleema and SOGP Secretariat, for providing us the opportunity to join this forum as panelists. I'm really thankful to you all.
Thank you very much, dear Professor Naseem and Dr. Mariam. And now we move on, and I invite Professor Muhammad Tayyab, who has been the past Vice President SOGP and currently is member of the Academic Board SOGP. He is teacher of the teachers and he is mentors of the mentors and one of the very favorites. So, sir, can we have your comments, please?
So, do we have Professor Tayyab among the panelists? The admin can let me know.
Madam,
Meanwhile,
Dr. Tayyab is not here as a panelist right now.
so while we'll try to get Professor Tayyab on the
Can we, in the meantime,
webinar, we can discuss few questions.
Yes.
So there was a question that what is the role of epigenetics in the development of the fetus in utero? I could see that question and that has gathered my, like say, gaze on it. So I would request Professor Shama, if she's still on with us. Madam, can you answer the question, please?
Actually, there are several factors, epigenetic factors, which are being studied. And at this moment, like, the environmental factors, maternal nutrition, how the exposure and other things can affect the phenotype. But what I feel is that before we go and discuss all this, there are a few queries that we need to resolve. Number one is that for all intents and purposes, for the last decade or so, the fetal growth restriction is the standard sort of a definition or standard format used, not IUGR or intrauterine growth restriction. So like, you know, we need to be with that. And also there has been a lot of studies on the epigenetic factors and things, but it's rather complex and beyond the domain of this sort of presentation today. But what I feel is that for those that are attending this, I feel that we should also highlight that the screening by uterine artery can be done as early as first trimester and not necessarily wait till 20 weeks, because many times you would have, if the woman comes early, you would have her early and you can answer her queries and, you know, identify and stratify her in a sort of a high risk group, and you would know which ones you would need to see more often, because there are low risk women that, you know, you don't need to worry about that much. तो वो जो customized care है उसका एक concept है, और जितनी early हम अपनी screening शुरू करेंगे उतनी early, जैसे हम first trimester में nuchal translucency करते हैं, उसी के साथ cervical length करें, उसी के साथ uterine artery Doppler करें, तो आपको एक stratification में बहुत आसानी हो जाएगी.
Right, madam. Thank you very much for the response. And
Professor Nudrat, I'm very sorry to interrupt at this moment. Actually, Professor Tayyab somehow could not get connected to the Zoom link. He is on a phone call with me, and on my hands-free on Zoom.
He would be giving his comments.
all right, madam.
Sir, please, you can talk.
Very much, Professor Haleema.
Let me check with people if they are able to hear it.
Hello, can anyone hear?
Yes.
I can hear.
Okay, good. Good. My apologies. I think that instead of the people saying I'm not present, I'm present since 4 p.m. and I've listened to every single word that has been said. It would have been useful if they had just checked out whether the audio is video. Anyways, that's behind. Let me first of all thank the SOGP for giving me this opportunity, learning opportunity, and these excellent talks from Professor Shama and Dr. Musarrat. And I feel that certainly one of the greatest advantages of such meetings is that you know, you come out wiser from them and you can incorporate a lot of things in your practice. I would just like to make a few practical comments. Beginning with, I was making, so I thought I'll have a video link so I'll be able to display some notes that I have made in the last 2 hours. But I'll just mention a few practical things. And to begin with, the terminology of IUGR, I think, is now obsolete from all the latest literature that I've been reading over the last few years. IUGR is no longer used as a terminology in recent few years. It's just FGR, fetal growth restriction. Second thing I wanted to highlight was the fact that maybe it's not been emphasized enough. Practical point is that it is extremely crucial and vital to date a pregnancy before we start taking the decisions. One of the dilemmas we have in our public sector hospitals particularly is that we get a lot of patients, perhaps more than 50% of patients who are so-called unbooked patients who have never seen anyone. They just appear in the 3rd trimester. Sometimes they just appear at that time and you have absolutely no clue, and especially if they have conceived during lactational amenorrhea or they've had irregular cycles. There is just no way of looking at a patient once and taking a decision. You can say that this is possible as GA, but you can never tell about SGR. And therefore, if you have somebody, especially for younger generation and future generations, and they have the facility available, it's crucial to date a pregnancy between 8 and 14 weeks with a CRL. And to understand that if that is getting delayed, then the 2nd trimester is difficult to date a pregnancy, even if somebody quality of an ultrasound and the use and the expertise available for ultrasound. I know there are certain units, both in private and public sectors, which do not have an ultrasound or do not have enough ultrasound. I believe ultrasound should be available in every gynae unit where training is being done. I believe all the doctors should be adept at doing ultrasound scanning. And I think in MRCOG there's a definite module for ultrasound, and perhaps we should incorporate that in our local training and local milieu as well, because that is where at least some people will be able to pick up the problem where the problem is there. Next thing I wanted to highlight was the practical use of habit, I would say, of using the symphysiofundal height on a regular basis from 24 weeks onwards. I have just concluded the FCPS examination in the last 6 days, and as always, my feeling was that some of the candidates who are now feeling in FCPS and clearing it too, but perhaps using the tape measure for the very first time in the exam of symphysiofundal height, which was very interesting, because it gave the impression that they're not using it as a routine, and it's not considered that perhaps because we don't use it as a habit, then we do not incorporate it into our daily practice. And only if we are adept in using it, and only then we'll be able to use it in high-risk pregnancies, which we are monitoring. The next thing I wanted to say was just to emphasize, and I think Shama has also mentioned, and Dr. Musarrat also mentioned, that every SGA is not FGR. Small for gestational, you get the suspicion that it's SGA, and you find that only 30% of patients, 3 out of 10, will actually be fetal growth restricted, and the majority of them are just a small for gestational age, so that's constitutionally normal without risk factors. And from my training years in United Kingdom from 1992 to 1995, where the customized growth charts were not yet available, it was very interesting that from Asian patients from India, Pakistan, and Bangladesh, the pickup or the spotting of SGA was commoner. And I always used to smile and say, oh, look, you always say to women of my ethnic origin that they all have small babies. Not necessarily. If you are going to customize the charts, you will probably find out that most of them were just normal. The next thing I wanted to mention was, I'm not sure, and this is just a thought that I'll float around the people who are tuned in and listening, is how many of us are actually using centile charts on patients who are whom we suspect growth restriction. Shama, obviously, you got an eye on Shama, and I know that you must be using. But how many of us who are busy obstetricians regularly, because we know that 1 in 10 pregnancies on average will be SGA, and we also know that 1/3 or 3 out of 10, 3 out of those would probably be FGR. But how many of us are actually using centile charts? And in the centile charts, we know that we don't know which centile chart is the best to use. And then also, you would all have noted that both these illustrious speakers have not used the word symmetrical IUGR and asymmetrical IUGR, which some people are still using. And they are neither, these are just ways of mentioning that you're looking at somebody who's a fetus who is smaller right from the beginning, or a fetus who is going to lag behind in later times. And also, I think we need to remember that one of the things that we're worried about when we're looking clinically at any patients who have probable SGA, and especially if they've got FGR, is the fetal impact in the short term, medium term, and long term. And the thing that I just like to highlight in this note is in shorter term of impact, obviously we're worried about stillbirth or neonatal morbidity, or we are especially worried about an FGR whom we're going to deliver premature, because they have a much higher risk of morbidity and mortality if it's FGR plus prematurity. But sometimes we are really in a no-win situation, and damned if you leave it inside and damned if you take it outside. But these are the dilemmas that we learn from. But especially, I think over the last decade or so, it's the increasing knowledge or availability of of information that in the medium term, if you're looking at the possible medical palsy or neurodevelopmental abnormalities or behavioral problems, or especially reduced intellectual attainment in later life, these are medium-term problems of fetal impact, and they are really worrying at times, and worrying for the parents who are in access to media, and they are looking at Google and all that. And obviously now there is enough information or enough theories and hypotheses about long-term impacts, about fetal programming, of the interplay of genetics and in utero environment of later in life metabolic syndrome, cardiovascular disease, and stroke. Then there's a couple of last points. The UK guidelines on if you're looking at IUGR, what is the best time to deliver? Because the RCOG guideline from 2014 would say 37 weeks plus, but the the NHS guidelines from 2019 would say 39 plus. And I believe in Pakistan, firstly, if you're not sure of what the date is in terms of exact dating, or secondly, especially if you're there and you're looking at that, a lot depends on the facility that you have available in your hospital for neonatal backup, which is very important. That's where we talk about in utero transfer or ex utero transfer. And finally, I would just like to compliment Dr. Musarrat Hasan. I've known him for 30 years, and sir, there are not many people in Pakistan like you. अब हम क्या करें कि अगर बाकी शहरों में मुसरत नहीं है तो कहाँ जाएं? तो मुझे नहीं पता कि how many people can actually give us accurate message. ये पॉइंट रेज करना चाहता हूँ. मुझे नहीं मालूम कि हमें कितने लोग accurate डॉक्टर रिपोर्ट देते हैं और कितने लोग वो वाली डॉक्टर रिपोर्ट देते हैं जो कि हमें एक्चुअली चाहिए, क्योंकि हमारे क्लिनिकल डिसीजंस उस पर बेस्ड हैं. So आप agree करेंगे कि it's very important to have an accurate doctor. We can't just look at from a dubious source and take clinical decisions, because that can have severe impact on the outcome for the mother and the baby. And हमारी जो जितनी बात तफसील से बात शमा ने की, and I always learn from Professor Shama, कि ट्रेनिंग ऑफ यंगस्टर्स बिजी हॉस्पिटल्स, हमारे जो बिजी हॉस्पिटल्स हैं, गकाराम है या जिना हॉस्पिटल है या लाहौर जनरल हॉस्पिटल है या लेडी विलिंगडन, these are the places जो 500 400 पेशेंट दिन में बुला रहे होते हैं. तो उसके अंदर हमारी जो यंगस्टर्स जो ट्रेनिंग है वो बड़ी इंपॉर्टेंट है कि वो स्पॉट कर लें उन पेशेंट्स को, टिक करें और उसके बाद उनकी मॉनिटरिंग थोड़ी सी ज्यादा इंटेंसिव करने की जरूरत है. और एक आखिरी बात एक किस्से से खत्म करता हूँ जो मेरे साथ पेश सिर्फ 3-4 दिन पहले आया था. Even at my level of seniority, where people would, want to trust a senior obstetrician, I spotted and picked up a small gestation age baby, by the gestation थी, कहीं ग्रेविडा थी, और मैंने उसके पेट पे हाथ रखते ही मुझे लगा और मैंने उसको 3-4 सेंटीमीटर का लैग आया, क्योंकि वो एक महीने के बाद दिखा. कोविड में हम मुसीबत ये कि हम सुनती नहीं सकते, बाद बुला भी नहीं रहे हैं. तो मैंने फटाफट टिक करके उसको उसी वक्त एक अच्छे अल्ट्रासाउंड पर भेजा, जिसने वो सारे के सारे पैरामीटर शो कर दिए कि उसका रिफ्लेक्स भी आया था, पीआई भी आया था, उसके अंदर लाइकर भी कम था, एस्टिमेटेड वेट भी कम था, और वो सब कुछ सारी, और अगले ही दिन उसकी सीटीजी फ्लैट हुई. लेकिन जब उसको डिलीवरी के लिए मैं घर से भागा तो मुझे पता चला कि फैमिली ने उधर मचाया था कि ठहरे हमें बताया क्यों नहीं गया कि बेबी को कोई प्रॉब्लम है, हमें आज क्यों बताया जा रहा है कि बेबी को कोई प्रॉब्लम है. वो तो खुशकिस्मती से आउटकम 1.7 kg का बेबी 35 वीक्स पे निकला. लेकिन मैं ये सोच रहा था कि बजाय इसके ये फैमिली शुक्रिया अदा करती कि मैंने टिक कर लिया प्रॉब्लम और एक्ट कर लिया, खुद कर लिया है, और बेबी अल्हम्दुलिल्लाह ठीक ठाक हो गया. वो घर भी चला गया 1.7 का, लेकिन वो इस बात से माफ करने को तैयार नहीं है कि ठहर जाएंगे, हमें बताया क्यों नहीं गया कि बेबी को कोई प्रॉब्लम है. और शमा ने अभी हाईलाइट किया है कि ये लेट IUGR बड़ी डिफिकल्ट होते हैं टिक करने भी. और अभी मैं लिटरेचर में मैं पढ़ रहा था कल, क्योंकि आई वाज प्रिपेयरिंग फॉर दिस सेमिनार, कि 2 out of 5 पेशेंट्स को आप टिक ही नहीं कर सकते. लेट IUGR मैं बोल रहा हूँ, लेट SCS जो है आप टिक ही नहीं कर पाते, जो about 2 out of 5, which is a high number, and therefore you have to have a strong index of suspicion. So I think एक चीज जो आखिरी किस्से के पॉइंट ऑफ व्यू से ऐड करना चाह रहा था कि हमारी जो ओरिएंटेशन और ट्रेनिंग काउंसलिंग के लिए है, हमारे कल्चर की काउंसलिंग वेस्टर्न काउंसलिंग से डिफरेंट है. वहाँ पे तो 10-20 वीक मिडिल ऑफ प्रेगनेंसी में तो डिस्कशन शुरू हो जाती हैं कि इन्वॉल्व की, और उनको डेटा दें और उनसे डेटा लें और उनसे कि आप सोच के हमें बताएं. पाकिस्तान में लॉट ऑफ पीपल वुड ट्रस्ट व्हाट द डॉक्टर से, एट द सेम टाइम हमें अपने कल्चरल वैल्यू के हिसाब से जो है ना वो काउंसलिंग को अंडरस्टैंड भी करने की जरूरत है. और थैंक यू वेरी मच फॉर लिसनिंग. दैट्स ऑल आई हैव टू से.
Thank you, sir. Thank you very much. You stay online so that if we need some other comments from that. Okay. Dr. Nudrat, I would just like to confirm, was it all audible to everyone?
Yes, that was audible, and thank you very much, Professor Tayyab. Now I would request my friend, Professor Haleema Yasmin, who's the Secretary General of SOGP, and a very dynamic and a very studious and a very research-oriented friend of mine. Ji, madam, for your vote of thanks, please.
Okay. I just wanted to make sure कि Professor Tayyab की आवाज सबको चली गई है या नहीं?
हमें तो आ रही थी.
Yes,
great.
yes, ma'am. Very much audible.
If any comment from the panelists or the speakers, Dr. Musarrat, you are there at London today. If you would
Yeah,
like
yeah.
to.
Thank you very much. I also enjoyed it. Thank you very much for giving me the opportunity. I think it went all well. Thank you very much. Nothing to add more. And there were some comments made by people that it should be, make it more hands-on and things like that. That should be done. And as Professor Tayyab said, that we should have more seminars and more teaching facilities for, at different hospitals with a good machine and good people to do ultrasound. I agree with him 100%. Thank you very much for his comments, and it was very nice. Thank you very much, Professor Haleema.
Thank you. Dr. Shama, if you would like to conclude at your end, any pertinent message?
Thank you, Professor Haleema. I just want to say that in my presentation, I think I should have more stress on one of the points that, whenever you make a decision to deliver somebody, then not only should you do your counseling, but sit with your pediatric colleague also, because it is absolutely essential, because they are at the receiving end, and we have got our own गाइडलाइंस हमारे पास तो अपनी हैं, और हम कभी भी किसी को डिलीवर कराते हैं, भले 35-36 वीक्स हो, यानी टर्म से नीचे ही हो, एक हफ्ता 10 दिन, तो भी we tell our pediatric colleagues, we check with them, they are aware कि हाँ भाई आपने रिसीव करना है बेबी, ये ना हो कि पता ना हो। दूसरी चीज ये है कि यहाँ से कोई ऐसा मैसेज नहीं जाना चाहिए कि सीवियर IUGR है, 24 weeks है, 26 weeks है, you have to counsel your patients, either send them to a tertiary care center, and many times if you sit with them, many people will say कि आपको पता नहीं चल रहा, अगर बच्चा इतना छोटा है अभी से, हमारे पास ना इतने पैसे हैं ना वसाइल हैं, आप इसको नॉर्मली जैसे आप कंजर्वेटिवली मैनेज करते हैं वैसे ही करें। So you have to keep that dialogue going on and respect the wishes of the family and everything, because obviously the NICU care also comes with a price. That's all I have to say.
Okay, so I'm really pleased and honored to present this formal vote of thanks to the whole panel today. My special thanks to the both speakers, Madam Professor Shama Munim, Dr. Musarrat Hasan, very senior members of SOGP, and they have really done the justice to the topic of fetal growth restriction. Our chair for today, Professor Muhammad Tayyab, a very valuable suggestion from him of using our clinical skills and tools which are available, like a simple tool like a measuring tape. If we can bring in difference in our diagnosis, just picking one more case by use of a tape rather than using my fingers, I think we should opt for this attitude rather than hame bahut aata hai type attitude. And then the moderator for today, Madam Professor Nudrat Sohail, our inshallah coming up soon, the chair of the Gujranwala chapter, inshallah, Madam will take this up. And currently she is the executive of Lahore chapter. Both the panelists for today, Dr. Mariam Zubair from Azad Jammu Kashmir and Madam Naseem Saba from DI Khan, and all the worthy audience who have joined us today on Zoom as well as on Facebook. Thank you very much, Professor Razia Korejo, for giving this opportunity to the SOGP team for conducting these academic webinars regularly. And thank you very much, SAMI Pharmaceuticals, for your support for this webinar. I again thank you all for this wonderful talk, and it was really a treat to listen to you both. Thank you again. Thank you very much. Allah Hafiz. Have a good evening and a good weekend.
Thank you.
Thank you, and to you as well. Thank you.
Bye-bye.
Thank you.
Thank you very much. Bye-bye.
Thank you. Allah Hafiz.
Khuda Hafiz. Khuda Hafiz. Khuda Hafiz.